Hey everybody, and welcome back. This week we're going to talk about pacemaker codes, decoding the pacemakers, and all the facts and information that you can get from a patient wallet card. Now, if you're like me, you probably don't know a lot about pacemakers coming out of medic school, so let's talk about pacemakers and pacemaker codes and the detailed history of pacemakers, because it's actually fairly interesting to learn. So with pacemakers, you might be wondering, what do all those codes mean? And there are several codes that come to mind. You know, you've probably seen them on wallet codes: VOO, VVIR, AAI, DDDR, and that may seem like a bit of a mystery, but we'll go over those in detail and find out exactly what those mean for you and for your patients. So to do that, we're going to have to cover a little bit of pacemaker history. And bear with me because it's actually semi-interesting. So pacemakers weren't always around, obviously, and they were invented by a gentleman by the name of Dr. Paul Zoll. And that name might be familiar to some of you. And he is the founder of Zoll Medical Corp, which makes the Zoll cardiac monitors and defibrillators. Paul Zoll created one of the first external transcutaneous pacemakers available commercially on the market at all. The two options available were either you pace them transcutaneously or you do a transvenous pacemaker, and they both have their own pros and cons. The pros of the transvenous pacemaker is it's a little bit more comfortable for the patient. It doesn't activate all the thoracic muscles when it paces, but the downside is that it does have an infection risk. So the downside of the transcutaneous pacemaker is unfortunately a little bit of discomfort that's associated with that. So there's pros and cons with either approach. So this is the first pacemaker, transcutaneous pacemaker, that was invented by Dr. Paul Zoll. This is the Electrodyne PM65 pacemaker, and the pacemaker has been used on this patient. This is the very first patient to have the Electrodyne pacemaker applied. Now, the downside with this one is it's powered by AC power. So your world, your life is pretty much tethered to an electrical outlet. But still, given some of the alternatives, this is better than nothing. Now, the pacemaker that Dr. Paul Zoll invented was a pacemaker that only paces the ventricles, and it doesn't actually sense anything. So it can only really be used in patients who don't have any native impulses of their own. Because if they do have their own heartbeat, this might have a fairly dangerous phenomenon called R-on-T. So when you have continuous pacing without any sort of sensing, this is the sort of EKG that you would see. Now you can see everything's marching along just fine until starting around beat 46 here in the picture. That's where you see that the spike for the pacemaker is actually landing in the T wave, which is actually quite dangerous. And we'll see why as you progress on towards beat 55. Right afterwards, you get an R-on-T phenomenon, which causes the patient to devolve into a cardiac dysrhythmia. So that is the downside of a pacemaker that doesn't actually sense what the underlying cardiac activity is. You could get an R-on-T, but given the technology they had at the time, this was the only option they really had available. That is to say, until these gentlemen came along. These gentlemen are doctors Aubrey Letham and bioengineer Jeffrey Davis. And they are a British bunch, and you can tell by the fancy corncob pipe and just their general appearance. But this was conducted in the UK, where they developed a new type of pacemaker. And this new type of pacemaker was this one right over here. This is the first true demand pacemaker, meaning it'll sense to see if you have an underlying rhythm, and if you don't have a depolarization of your ventricles occurring, well, it'll give you an impulse to do so. And this looks like a telephone handset. In fact, it is a telephone handset that they used and hollowed out and put pacing electrodes right into the handset. So it's kind of comical almost. It's almost like you're giving a heart a phone call to let it know to keep beating, But the glory of this machine is that it would sense your underlying rhythm. It would provide an impulse when you don't have one. But still, this is transcutaneous, and one of the downsides of the transcutaneous pacemaker is the pain and discomfort that it causes. In fact, in the very first case of this being used, this particular model being used in the UK, the night nurse turned off the pacemaker because it was too painful and the patient died. So, ironically enough, 50 years later, the first person I paced as a paramedic, the receiving nurse said, "Oh, the patient's unconscious. Patient's conscious. She doesn't need this," and ripped off the pacemaker pads. And the patient went unresponsive with a rate in the 30s again. So, 50 years later, same kind of stuff happening. So, that was the, transcutaneous pacemaker. So this gentleman over here, some of you may recognize as Wilson Greatbatch of the University of Buffalo fame. He was an electrical engineer who accidentally stumbled upon the circuit design for an implantable pacemaker. He did this entirely by accident, and he was designing a completely different circuit. But the quote from him is, when he was interviewed later as to how he created this, he says, "It was no accident. The Lord was working through me. The oscillator required a 10 kiloohm resistor at the transistor base. I reached into my resistor box for one, but I misread the color coding and got a 1 megaohm resistor by mistake." And for anyone who's played with any sort of electronics or resistors, reading those color codes is actually sometimes a little bit tricky and difficult. So when he plugged in the resistor, the circuit started to fire with a 1.8 millisecond pulse, followed by a 1 second interval where there was no activity, no electroactivity through the transistor whatsoever, and it drew practically no current. So Wilson Greatbatch kind of recognized what he had going. He realized that this device could be implanted into a patient and continuously pace their heart. So while this idea was great, it took a little bit of effort to actually convince someone to, advance this idea and do something with it, because this was a revolutionary idea. So he spoke with the gentleman at the Buffalo Veterans Hospital, and they went up to the animal lab. And when they implanted this device and connected the electrodes into a canine heart, the heart would beat in synchrony with the pacemaker that was implanted. So they became known as the bow tie trio. The two doctors in Wilson Greatbatch always wore bow ties. So he would go on to do animal studies for 2 years, and was on track to make the very first pacemaker. That is, unfortunately for him, until these two gentlemen arrived. This is Dr. Rune Elmquist and Dr. Ake Senning. They're a Swedish bunch, and there's also a patient involved, or more specifically, a patient's nagging wife. A patient named Arnie Larson was hospitalized with multiple Stokes-Adams attacks and complete heart blocks, as many as 20 or 30 times per day. His wife knew that these two doctors were developing an implantable pacemaker and nagged them several times a day, driving to their lab, until they said, "Okay, fine already, geez, we'll make it." So they hollowed out one of these shoe polish tins, poured in some resin over a couple components, and created this. The first implanted pacemaker ever. They actually made 2 of them, and they implanted it into a patient. They did it sort of in the dead of night, so no one would ask questions. Someone coming in and implanting this device that's really not really approved or really tested. So they wanted to avoid any sort of controversy or questions about the process. So the first one they implanted lasted for about 8 hours. And unfortunately, the pacemaker failed at that point. And, they found out it was because they nicked one of the transistors when they were making this up. But fortunately, they had a backup pacemaker back in their lab. Got their backup pacemaker, put it in, and paced the patient. And successfully. The patient, went on to live for quite some time. Dr. Senning was quoted, "In the 1950s, we didn't have any liability problems. The patient and the relatives were happy if the patient survived." Well, he did survive, but he ultimately did die in 2001 of cancer after 22 different pacemakers and 5 different lead systems. And in fact, he even outlived the doctors who implanted his pacemaker. So that brings us right back to present day. So let's talk about pacemakers. There was a number of different pacemakers that have advanced since the 1950s. So they've come quite a ways, and we can have ventricular pacemakers, we can have atrial pacemakers, we can pace both chambers, we can pace one or the other alternatively. So how do we keep track of all these different pacemakers in the different modes? Well, the British and the American societies came together and developed a multinational, universal almost code to help people understand the differences. And this is the 5-digit pacemaker code. By general convention, we only really use mostly the first 3, or maybe sometimes the first 4. The first 3 are really key to tell you, exactly what it's doing, what's being paced, and how it's being paced. So let's take a look at the different pacemaker positions here. So in the very first digit, we have what chamber is being paced, whether it's the atria or the ventricles. So it's the first letter that actually tells us what's being paced, the A, the V, or in some newer pacemakers, dual chamber, the top and the bottom are both being paced. So the second digit that's in the pacemaker code is what chamber is being sensed. Where is it looking to find out what to do, specifically whether to pace or not pace? And it could look either in the atria, the ventricles, in both chambers, or none. And the very first transcutaneous pacemaker, as I mentioned, didn't have any sort of sensing ability. So it actually sensed none of the chambers. The third digit is, great, we sensed something. Well, now what? What do we do with that information? And there's a couple things that could be done. You could sense a beat, and you could trigger a paced beat. You could inhibit a beat if you are planning to pace and another natural impulse occurred. We can stop a paced beat from occurring right afterwards, specifically, especially right on the T wave. You could do both. You could inhibit and you could trigger depending on the rate and the timing, or you could do none of the above. So you have a number of options to choose from as to what it could do. So let's go over a couple different pacemaker appearances here. So this is a VOO pacemaker. And what that means is that it's the ventricle that's being paced. That's the first position. It's not sensing anything, and since it's not sensing anything, it's not doing anything about it. So it's just a continuous pacing of the ventricles. This mode nowadays is fairly rare. Most, if not all, pacemakers are programmed to do at least some sort of sensing, just because of the risks and downsides of pacing on a T-wave. The next one here is an AOO pacemaker. So they put the pace-making cable down into the ventricle, and they paced the ventricle, and they said, great, well, what else can we do with this? So they actually can put a pacemaker cable up into the atria instead. You can just pace the atria. And AOO means that it just paces the atria continuously, and it doesn't sense or inhibit any sort of natural beats. This is great for someone who's got an intact conduction system. So if your AV node and your His-Purkinje network all works fine, and it's just a matter of you've got a bum sinus node, and that's really all that's wrong with the conduction system of your heart, this might actually work well for you. Again, nowadays they at least have some sort of internal sensing to prevent additional beats when not necessary. But this is a mode that could be used. So the next one is VVI. This is one of the most common modes that you will see. This is ventricular pacing, ventricular sensing, and inhibiting when it senses a native beat. So if you take a look over here, this has a paced rhythm here, and after the second paced beat, you see a different morphology QRS complex. This is probably a natural occurring, spontaneous beat. So the pacemaker says, hold on a second, we don't need to pace. The heart did its job. Let's wait to see if it does it again. And if not, we'll take over and we'll go back to pacing. So I mentioned that the AOO mode was not used all too often, and that's because AAI is more common. And this is the same sort of deal where it's pacing the atria, and you'll notice after just on the very top line there, right over here, there is a spontaneous atrial beat. Sinus beat perhaps, I'm not sure where it might be originating from, but there was a normal complex. So the pacemaker says, okay, I don't need to pace right now. I need to pace the atria because some depolarization happened and I can take a break for now. And then you can see it goes back into pacing when there's not another beat following it. And the last one is a DDD pacemaker. This is probably one of the more common modes that you'll see. This is whether it can pace the top of the heart or the bottom of the heart, the atria and the ventricles, and it can alternate between any of the needs depending on the native rate and physiology. And this EKG here was lifted from the folks over at ecgmedicaltraining.com. As you can see, it shows all the different morphologies of possible permutations of this paced beat. The first circled one, that's an atrial paced beat. You pace the atria, and then the ventricle is depolarized. It sensed the ventricle is depolarized and said, okay, good, I don't need to do anything about it. Then immediately right after that, it paced the atria, and the ventricles didn't respond within that time frame. They said, well, all right, I guess I'll pace the ventricles too. So that's why you can see two spikes. It paces the atria, it paces the ventricles, based on whether it sees a response from whatever it's sensing or not. And then it goes on to the third circled beat, the second circled beat. The atria depolarized, so the pacemaker said, okay, I don't need to fire and depolarize the atria. Let's inhibit that. And then it waited, set time frame, and then the ventricles fired. And it said, all right, I don't need to do anything about this. This works. And this is for people who have some very intermittent issues with their conduction. And then, of course, the third one is the full atria and ventricles paced. Or the fourth one over here that's circled is the one that is the atria have depolarized and waiting for the ventricles to depolarize. Nothing has happened, so it paces the ventricle. So there's the benefit of that is that if you have both the atria and the ventricles firing, you get some additional cardiac output. About 25% of the cardiac output is from that atrial preload of the ventricles. And without that, you have decrease in your cardiac output and, I guess, a worse overall condition. So they've done a number of studies. They found that, if at all possible, they prefer to pace the atria if they don't have a natural rhythm in the atria, because this decreases things like thrombus formation and decreases instances of atrial fibrillation. So they'll pace the atria if there's nothing happening over there. But the DDD pacemakers will sense and pace whatever it feels it needs to be paced at that particular time. So it's like a smart pacemaker. So the next thing we need to talk about is the fourth digit. Now, the fourth digit used to have a slightly different purpose. The fourth digit used to denote programming options, like whether you could communicate with it with set parameters, like sensing, output, more complex features like event recording, and whether it's able to accept parameters. And pretty much all pacemakers nowadays, since the 1970s, have had some degree of programming. Almost all of them now are multi-mode programmable, so they have a full feature set of things that can be programmed and tailored, to the individual patients. So that's more or less gone out the window. So all that it's being used for now, the only other thing that it could tell you is whether it is rate responsive or whether it is without rate response. And rate response means that the pacemaker will adjust its native rate based on uh, what it perceives to be the natural demand for the heart rate. There's a couple different methods of this rate adaptation. Most of them focus on like small piezoelectric accelerometers to measure activity and ramp up according to that. Some use electrical changes in the leads caused by breathing patterns because they use the breathing pattern as a surrogate for increased metabolic demand and therefore theoretically increased demand on cardiac output. There is a new technology that was being looked at. I'm not sure if they've actually continued to develop it, but they were looking at some changes to the terminal T wave to correspond with different metabolic changes and calculating that out and changing the rate based on that. I'm not sure if that's developed, but that was one thing that was being looked at. And then the last position here is multi-site pacing modes. This really doesn't make a huge difference to us in the pre-hospital setting. It just means, are we pacing, one atria? Are we doing multi-atrial sites, multi-ventricular sites, or none of the above? So you'll typically see just the first three, if not, maybe the first four. Like a DDDR is one of the more common descriptors you'll find on a patient's pacemaker card. So there's some other features as well that you'll see on pacemakers. One of the features that you'll see is overdrive pacing. Now, overdrive pacing is a way to break a patient out of a tachydysrhythmia. And it does this by pacing faster. Now, it seems counterintuitive to pace faster than the heart rhythm that you're trying to break, but it actually makes sense. If you think about the heart physiology, the fastest pacemaker wins. So the pacemaker tries to take over and be the fastest pacemaker. And when it takes over, eventually it will also capture and depolarize the site that is causing the ectopy. So it'll pace several times in a row, and then it'll stop and go back to a normal mode. So that's how it does overdrive pacing. So if you see rapid spikes in a row, the pacemaker's not broken and suddenly pacing faster than it needs to. It's trying to break a tachycardic rhythm and reset. So another way that it can break a tachycardic rhythm is through an internal cardioverter defibrillator, sometimes called an SICD or subcutaneous internal cardioverter defibrillator, which I think is redundant with the internal part, but that's one of the terms that they used. Or more commonly, we'll call it an AICD, an automated internal cardioverter defibrillator. So let's take a look at some of these over here. This was pulled off of a pacemaker, and you can see that it sensed a tachycardia and it cardioverted. In this case, this pacemaker also has the feature of event logging. Now, unfortunately for this patient, they didn't really need to be cardioverted. So there's the feature that will allow people to look back and figure out why they were cardioverted and what was causing it. So in this case, it was a little bit of noise on the sensing line, so that falsely triggered the cardioversion feature. One of the other features of pacemakers, ever since they added additional modes, is that they all have pacemaker magnets that can be used with this. Now, what's the utility of a magnet? Well, a magnet can change the mode that the pacemaker is pacing in. If you think about a VNS stimulator, a VNS stimulator will actually, if you put the magnet right over the stimulator, it will actually trigger the device to stop a seizure. So this actually sort of works like that, but the opposite. A pacemaker magnet shuts off a lot of the features of the pacemaker. It changes it from whatever its native programmed rate is. It sets it back to being a VOO pacemaker. It'll just pace the ventricles, and it won't sense, it won't time anything, it won't trigger anything. It will just pace the ventricles at a set continuous rate. And this is useful for things like diagnostics. They can actually figure out the battery, because when it goes to that set rate, if there is a dip in voltage, the timing between the spikes will actually decrease a little bit, and so will some other features like amplitude. So they can actually look and see what the patient's pacemaker battery status is by using a pacemaker magnet. This is often coupled with like an EKG that is sent over a telephone. This is all sort of more of an older school approach. Nowadays, it's a lot easier and a lot safer for the patients for the pacemaker to just be interrogated to find out all these parameters and more at their regular cardiologist follow-up. This also will turn off the anti-tachycardia and dysrhythmia feature of AICDs. So that potentially has some risks and downsides. If someone's using a pacemaker magnet, it can trigger an RNT and disable the feature that will shock them back into a normal rhythm. So that's why they've sort of gone away a little bit from using those, but they're still around, and you'll see them, in fact, in many code rooms. You'll see these donuts stuck to the wall. And these donuts are actually fairly powerful. They're a donut ring magnet, so it channels a lot of the electromagnetic current right through the center. And it's fantastic for doing things like erasing credit cards of your partner when you put it up against their wallet. I mean, not that I'm suggesting any pranks or anything, but I'm just saying, I'm just putting this out there. It's something that could happen. Anyways, so as you can see over here, when you apply the pacemaker magnet, it switches the modes. And this particular pacemaker in this strip happens to be one of the newer pacemakers with the dual chamber, the DDD pacemakers. And on DDD pacemakers, it doesn't change it to VOO mode, it changes to DOO mode. So it'll pace the atria, it'll pace the ventricles, and it paces it at a very specific interval between the two. I think it's about 120 milliseconds. So it's got a set gap and it's got a set rate. Otherwise, exactly the same. And the pacemaker magnets actually have some utility as well. It can break a dysrhythmia that's actually caused by the pacemaker itself. Something that we call pacemaker-mediated tachycardia, or pacemaker-mediated endless loop tachycardia. Two different ways of saying the same thing. And I think the pacemaker-mediated tachycardia, or PMT, is generally winning out in the lingo. It seems to be the preferred terminology used. I like the sound of P-melt because it sounds like a delicious sandwich, but maybe that's just me. So let's take a look and see what exactly this looks like. Because all we see is suddenly you see the big spikes, and they're happening very rapidly. Why is that? Well, we have to look at this. This is called a laddergram, the second line down, where it draws the current from the atria and the ventricles so that you can understand exactly what was happening. And this is data that's pulled off usually from a pacemaker report. And what happens is it senses the atria, and then it paces the ventricles, because it's an atrial sensing pacemaker. It will sense the atria and pace the ventricles. So this is probably a DDD pacemaker, and as you can see, actually, it's in DDD mode. And then suddenly you have a PAC that occurs, and then the ventricles pace. Now this paced impulse goes back up through the tissue and actually depolarizes the atria. And when it depolarizes the atria, the pacemaker says, "Oh, hey, cool! There's a depolarization here. I better pace the ventricles." So it paces the ventricles. Now this goes through the tissue, retrograde conduction, through an accessory pathway, and it depolarizes the atria. And this repeats. Now, modern pacemakers have a technology where they can diagnose and fix pacemaker-mediated tachycardia. After about 16 beats, the pacemaker goes, "Hey, wait a second. Something about this seems kind of suspicious." And once the pacemaker realizes that it's been had, it says, "All right, stop. We're not going to listen to anything in the atria. We're going to pause, and we're going to start pacing both chambers manually, and we'll take over from there." And that actually works in a majority of cases to terminate the pacemaker-mediated tachycardia. So now they've covered the pacemaker-mediated tachycardia, we should probably talk about some of the rest of the pacemaker-associated problems. Those problems are failure to pace, failure to sense, and failure to capture. So let's take them in a kind of a random order here. Let's talk about failure to capture. And that's when a pacemaker that is pacing, and you can see the paced impulses, fails to capture the myocardial tissue. And there's a couple of things that can cause that to occur. You could have an increased capture threshold. Normally, cardiac tissue captures at a certain milliamp threshold. And maybe there's some physiologic changes. Maybe there's some scar tissue forming around the probe. Maybe there's some degree of acidosis or some degree of unresponsiveness from the myocardial tissue itself that increases the amount of energy needed to capture those tissues. So as you can see here, this is a failure to capture. And another cause is sometimes you can have a lead fracture. Now these leads are designed to experience 10 to the 5th power bends per day. That's a lot of movement, but still enough bending and flexing back and forth can eventually cause that pacing cable to break or separate a little bit so that it can't get the appropriate energy through. Or sometimes it can introduce noise into the circuit. Another cause would be a lead displacement. If it gets pulled from the cardiac tissue and is free-floating, there's a certain syndrome called Twiddler syndrome. There's documented cases of people who would actually play with their pacemaker and just kind of fiddle with the pocket where the pacemaker is. And on one x-ray, they actually found that this gentleman had played with his pacemaker so much, he wound the pacemaker cable back up and away from the cardiac tissue where it was supposed to be pacing. So if you have a pacemaker, stop playing with it, please. The next failure is a failure to pace. As you can see here, pacer is pacing, and there's a gap where it should be pacing unless the set point is very low, but it doesn't. This could either be a continuous failure, where it just dies, or it could be transient and intermittent failures. And most of the common causes for this is a fracture of the pacing lead, where it introduces noise and it hears a lot of electrical activity going on, and it mistakes that for the heartbeat, which segues us into the next one, which is a failure to sense. Now, in a failure to sense, the pacemaker isn't sensing the underlying rhythm, or it's oversensing the rhythm that it thinks it's there. In this case, you can see that the pacemaker fired right on the T wave, and it's not supposed to do that as long as it's programmed in anything other than VOO mode. So what we have here is a failure to sense. So, like I said, a couple of causes. Most common, damage to the pacemaker lead that prevents it from sensing the energy required. And then there's the concept of oversensing. Now, I wasn't able to find a convenient picture for oversensing, but they are out there, and I have seen that. So there's a couple reasons why you can have oversensing. So oversensing, you could have a fracture that introduces the noise, like we were talking about, and that's one of the more common causes of oversensing. You could have a reentrant complex, sort of like the pacemaker-mediated tachycardia, but you could have a reentrant complex that causes it to sense the beat, or sense rather the electrical depolarization activity. Now, the pacemaker has no way of knowing whether this is associated with any mechanical activity, and there's really no way for it to tell. Its job is to sense electrical activity, and it does that very well. And this is the exact sort of situation where photoplethysmography, or the pulse ox pleth wave, would actually be very useful. This is the exact situation that I was talking about in Kelly Grayson's article on EMS1 about photoplethysmography. We had a call for a patient who was reported to be bradycardic, heart rate in the 40s, according to the visiting nurse. When we arrived on scene, the palpable radial pulse rate was 40. Put him on the cardiac monitor. Well, that's odd. His heart rate, electrical rate, is in the 80s. Well, that's peculiar. So we did some further digging, and we found that the first beat was a appropriately paced ventricular beat. But then he had a reentrant depolarization of the atria, and hence natural depolarization of the ventricles. So he essentially was creating his own PVCs, or PACs technically, that weren't actually perfusing. And you could tell that on the pulse ox pleth wave, whether there's perfusion associated with that electroactivity. So fortunately for this gentleman, he wasn't suffering any ailments from this. He was quite comfortable. So he did have an easy ride over to the hospital just for continuous monitoring and seeing if they can suppress that excess conduction. So oversensing can also be because of high T-wave amplitude. It's more common with electrical monitoring equipment like cardiac monitors, where it'll sense the high peak of the T-wave and it'll count that as another QRS. Not as common with pacemakers, but since it occurs with cardiac monitors, I figure it should be important to note a different form of oversensing. So if your heart rate is 60 and your cardiac monitor is telling you it's 120, there might be a chance that that's what's occurring here. So, to recap, we've gone over pacemaker history. We've talked about different pacemaker modes and pacemaker codes, and we've talked about a number of the pacemaker features, from the anti-tachycardia features to dysrhythmia features like the internal defib, the pacemaker magnets, and the event recording. And we've also talked about pacemaker failures. We've talked about the failure to capture, failure to pace, and failure to sense. Very rarely, but occasionally still occurring, you could have a failure to pace by a failure of the entire pulse generator itself. The pacemaker could fail. That's fairly rare. These devices go through rigorous quality controls and testing, but it is not unheard of for the pacemaker unit to fail. More commonly with long-lasting pacemakers several years in that don't get maintenance and don't get follow-up. These pacemakers run on batteries, and eventually these batteries could die. So hopefully it's not a situation where if the battery dies, the pacemaker dies. But it's one of the things to look out for. If they have a pacemaker, if it's not firing, it could also be because the pacemaker itself has failed. But that is fairly rare, and that's a fairly exceptional kind of failure. So hopefully that covers all of the questions you may have for cardiac pacemakers. We've covered a lot of different topics, but this has been quite the illuminating discussion, and I've enjoyed researching pacemakers because there's actually a lot of long-standing pacemaker history. I'll put an article in the link description down below that has some additional resources, some additional backstories on pacemakers in case you are curious. So until that time, ladies and gentlemen, I hope you have a